Welcome back from your break and your healthy interlude. We're going to get started with our next panel, and to do so, I'm going to invite Planning Committee member Peggy Wilmoth, who will come up and introduce the first of this year's 3 interactive panels focusing on healthcare economics and reimbursement. Peggy?
Thank you, Bob. Well, good afternoon, everyone. It's my pleasure to introduce the speakers and moderator for our first interactive plenary panel for this year's Academy meeting. This particular panel will focus on the economic implications of childhood poverty. Our first panelist for today is Dr. Charles Homer, the Deputy Assistant Secretary for Human Services Policy, Office of the Assistant Secretary for Planning and Evaluation, Department of Health and Human Services. Dr. Homer co-founded the National Institute for Children's Health Quality in 1999 and served as its president and CEO until he joined DHHS in 2015. Dr. Homer is an associate clinical professor of pediatrics at the Harvard Medical School and of the social and behavioral sciences at Harvard School of Public Health. He has a very distinguished record of public service at the state and national level, with a focus on improving systems that promote equity and the well-being of children and families. Our second panelist is Dr. Sandy McClowry, professor at New York University. She is one of our Academy Edge Runners, and she is the developer of Insights into Children's Temperament. Insights is an evidence-based intervention that enhances the social, emotional development, and academic skills of children, as well as the behavior management skills of parents and teachers. She was a Fulbright Scholar in Jamaica, where she adapted the program for use in their schools. Dr. McClowry has received extensive funding from the National Institutes of Nursing Research and other sources to support this innovative program that's designed to foster the social, emotional, behavioral development of children, especially in families with limited resources. Rear Admiral Sylvia Trent Adams is our third panelist. She is currently the Deputy Surgeon General, U.S. Public Health Service, where she supports the Surgeon General in the day-to-day operations of the Public Health Service. She has served in a variety of leadership capacities in the Public Health Service over the course of her career, including serving as their Chief Nursing Officer from 2013 to 2016. She deployed to West Africa and supported the Ebola epidemic in 2014. She also previously served as the Deputy Associate Administrator of HIV/AIDS Bureau at HRSA, among her many other leadership roles in the PHS. Rear Admiral Trent Adams has provided leadership on the national level as chair of the Federal Public Health Nurse Leadership Council and on the Federal Nursing Service Council. Prior to joining the PHS, she was a nurse in the U.S. Army. And our moderator for this afternoon's panel is our own Cheryl Sullivan, CEO of the American Academy of Nursing. Prior to joining the Academy, Cheryl had a storied career in public service. She served as the Deputy Chief of Staff for Policy for then U.S. Senator Evan Bayh and as Vice Chancellor for External Affairs for the Indiana University, Purdue University Indianapolis, better known as IUPUI. She also was the Principal Advisor on Social Service Policy to 2 different governors as their Cabinet Secretary for the Indiana Family and Social Services Administration. She worked on the Gore-Lieberman campaign in 2000 as their National Issues Director. I think after hearing the introductions of our panelists, you will agree that we have the right individuals and experts here to discuss the economic implications of childhood poverty. Thank you very much.
Well, good afternoon. The theme of our overall conference for the Academy is the economics of healthcare. And you just heard the keynote address on care transformation, the business case, and learned of the statistic of $470 billion of free healthcare, pretty staggering. So now we're going to turn to the economics of the implications of childhood poverty. And we have just some tremendous, tremendous speakers, and I thank each of them for joining us this afternoon. We're going to start by each of them just talking for about 3 or 4 minutes to set the stage, to identify the issue, and then we're going to have a conversation, and we invite you to listen in to our conversation, as well as to identify questions for us. So we're going to start with Sylvia. We're so glad you're here, and would like you just to start outlining the issues as you see it from your current and some of your previous jobs.
Sure, thank you. First, I wanted to acknowledge the fact that childhood poverty is a public health crisis. As we look across the United States and we look at the number of children who are born into poverty and remain in poverty for the span of most of the span of their lifetimes, it has a huge impact not only on their health status, but their ability to be successful in life. We know that poverty specifically impacts minority communities more so than non-minority communities. And I was looking at some of the statistics in preparation for this talk, and it was staggering to me that over the last 40 years, between 15 and 23% of the children in this country have been born into poverty. 40% of Black newborn children are born into poverty in comparison to 10% of white newborns. And when you look at the communities that are most impacted by poverty, they are all across the span of the United States, urban and rural. But when we look at the health impacts of poverty on children, we see that they're more likely to have chronic diseases early in life that are unable to be managed into their adulthood, such as increases in asthma that we know that we see in our own clinical practices. The environmental health impacts on children who are in poverty with exposures to unsafe drinking water, as we saw in Flint, and also increases in exposures to harmful precipitates from the environment from pollution. But one of the things that I think resonated with me across the span of my career, and my career has been primarily spent at HRSA working with poor and underserved communities.
And we are so grateful that you were there.
And I loved being in HRSA primarily because it allowed me the opportunity to get out in the community and to spend some time understanding the impact of health on those who are disadvantaged. Specifically for children who are exposed to not just poverty, but exposed to violence, chronic stress, and other factors that are associated with being in a poor community or having a poverty as a part of their makeup. But over the span of one's life, I think that we as a nation have an obligation, especially in the healthcare community, to figure out where best to invest our resources, and not just our finances, but our time and our talent to be able to address childhood poverty as a major healthcare crisis.
Great, thank you so much. Charlie.
Great. Well, thank you so much. It's really an honor and a pleasure to be here. By training, I'm a pediatrician. My clinical work has always involved providing care to poor families and poor children. When I was in medical school in West Philadelphia, after seeing a child with asthma in the emergency department, my faculty would have me go and do home visits and see what the conditions were for the children whom I cared for. I spent a semester in eastern Kentucky in Harlan County. For those of you who want to figure out numbers, that was back in 1978, and it was poor then. And what I remember most, actually, in hearing the earlier session, was traveling with visiting nurses in their four-wheel vehicles, driving up what they call the hollers, up the narrow valleys, to see families who didn't have the transportation, or perhaps because of interpersonal violence or substance use, wouldn't come to the clinics, and we'd give immunizations and check blood pressure and give insulin. When I was in Revere, Massachusetts, I took care of Cambodian refugees who survived the killing fields of Pol Pot. In all of these situations, I saw families that were trying their best but had almost insurmountable odds. My initial response was to say that, well, healthcare, the delivery of healthcare can do something, and we have an obligation as healthcare professionals to deliver the best services that we can. And I spent about 15 years working on how to improve the quality of the health services that we deliver to children. And it was rewarding, and it had an impact. But after a while, I felt it's time to move further upstream. and to really address the root causes of poverty. Now, I find it kind of an ironic question that people say, well, gee, how do we know that poverty causes poor health and what the impact is? I mean, think for a minute about what the definition of poverty is. Poverty means you don't have enough resources to provide the basic necessities of life. They're called basic necessities for a reason. If you don't have them, those are necessary for life and there's harm resulting. And somehow we seem to think that we're new discoverers of the relationship between poverty and health. But having the honor of being at this wonderful meeting, I couldn't but look to the writings of Florence Nightingale. I mean, she taught that the work we are speaking of has nothing to do with nursing disease, but with maintaining health by removing the things which disturb it: dirt, drink, diet, damp, drafts, and drains. Rudolf Virchow, similarly, in roughly the same time period, one of the fathers of medicine, said medicine is a social science, and politics is nothing else but medicine on a larger scale. So why have we had a bit of a change of heart recently? Well, some of it, and I'll be brief and then we can come back in questions, but some of it has to do with, as we've looked at healthcare reform and had all these conversations, we realized that we're spending a whole heck of a lot of money on the delivery of health services, and we're not, in fact, having a return on our investment. And that's because I think most of us know that a relatively small proportion of the variation in health outcomes, most people think somewhere between 15 and 20%, is due to the delivery of healthcare services. And the rest really relies on the socioeconomic conditions and the health behaviors that result from those socioeconomic conditions. So there's a recognition that if we want to, quote, bend the cost curve, we need to address the upstream determinants. We also have a much deeper biologic understanding of how poverty translates into adverse health impact, and we can discuss that later. I just want to mention a few other things. There's a sense that the poor will always be with us, and in fact, that what we need to do, like my work in healthcare, but maybe broadening it to working on things like early childhood education, a wonderful service, and nurse home visiting, again, a fantastic program. But what we really need to focus on is how do we ameliorate the conditions of the impact of poverty on poor children. I would contend that we actually have the capability to address poverty directly. I think there's a common misunderstanding, often heard in political circles, that we waged war on poverty and poverty won. Well, that's in fact not true. We in fact know, as we heard before, and it depends if you want, I'm happy to go into the arcane ways that we calculate poverty. Using something called the supplemental poverty measure, there are now about 11.9 million, around 16% of children, in fact, live below what we call the supplemental poverty measure. But we know that in the absence of the programs that we have, programs like the Earned Income Tax Credit, the Child Tax Credit, SNAP, the food stamp program, that poverty would be almost twice as high, it would be approximately 30%. And we know which of these programs is more effective, which reaches more children. We know, for example, that for those few individuals and families who were fortunate enough to receive housing support, such as housing vouchers, they're about 25% less likely to be in poverty, but we simply don't have enough housing vouchers to go around. I could go on. I'll stop here and look forward to our questions and discussion.
Thanks, Charlie. Sandy.
Thank you. I am delighted and honored to tell you about my journeys into homes and communities of children of poverty. Ironically, the journey begins in the hospital when I was a pediatric nurse caring for children on a unit that took great pride in having medicines and treatments done on time, food, healthy food, and a lot of developmental support. And wisely, after going back for my baccalaureate degree, my nursing professor in communities sent me to the homes of the children that I had cared for in the hospital. They weren't wearing nice little gowns. They weren't always well fed. And I remember sitting with one mom who was clearly overwhelmed by her new baby and her child with chronic illness, while the child played for the hour with a string. It was then that I thought, I need to go where the kids are going and into the community. I have been there a long time and been in many communities. And as you read the literature and talk to nurses, there are two things that are so relevant and so consistent. One is that the stressors of children of poverty and their families are multiplicative and interactive. And the second, which is equally strong, is that the protective process is the caregiving from people who really and truly do care. And so it is our challenge then to look at supporting the caregivers in order to help the children. I have been the PI of 3 generously funded studies testing the intervention I developed called Insights into Children's Development. And I want to say 2 things to my nursing colleagues. First of all, those of you who work with the elderly are not exempt from this. 1 out of 10 kids live in multi-generational homes. And that is disproportionately more of children in poverty. And not only do the children suffer in terms of their health and academic and social and emotional development, but so do the grandparents who are caring for them. I am so grateful my children are grown, and the thought of starting with a new generation just awes me as these parents with grandparents with few resources help to take care, and typically are primary caregivers of these children. And part of the reason is because many of the children live in communities where there are few jobs, and parents have to leave in order to support their children, or where substance use has interfered with their parenting ability. We've learned a lot of things from Insights. One is that we developed it in partnership with nursing, and it's comprehensive. It's for the parents, the teachers, and the children. So we're not only taking care of the children, we are taking care of the caregivers and giving them support. One of the major things that Insights does is it approaches it that one size does not fit all children. And so parenting and the strategies that we teach parents and teachers are based on the child's temperament. We have 4 exemplars. You'll laugh at the first one, but she was developed many years ago, Hillary the hard worker. Her opposite is Gregory the grumpy, Coretta the cautious, and Federico the friendly. And by using these tools, we can teach parents and teachers to recognize differences in children, not to change the children, but to understand that the strategies we use as caregivers have to be different and match children's temperament. And with all respect to my colleagues who are 0 to 5 experts, life does not end in kindergarten. In fact, schools provide a whole new environment with caregivers, teachers, school nurses, counselors, who can help children, particularly those who have not been nurtured as much as we like. And in turn, schools can nurture the caregivers. We have had a number of outcomes, and we've published, we've done all those things that you're most welcome to read on. But I want to give you from my clinical gut what it is that makes Insights work. And I think it is that we help parents and teachers understand what is unique about this particular child. And there is nothing more powerful than knowing you are accepted and cherished for who you are. So after 3 RCTs, I think we've done what we need to do to show that Insights works, and I've been going into other communities. I'll give you one anecdote from a recent experience. Remember, Insights was developed in urban New York City. So to have a bit of a change, I went to rural Appalachia, into a community as different and as poor as you can imagine, and then some. Avery County has a school district that is so concerned about their children. They really care. They have implemented technology from kindergarten to the 12th grade so that the children really learn. But the problem is that the community has no jobs. The entire economy is based on Christmas trees that are cut and shipped to our communities. That's a very limited amount of money. And so the children, when they finish, and they're doing so well in these wonderful schools, are then faced with the choice. Do they leave the community and their families, which are such an asset in rural Appalachia, or do they stay without jobs? Nurses are really well poised to deal with this. We are trilingual. We have been interprofessional for eons on time, and yet we can speak to our patients. Even more so, we can speak another language to those in power, those who have direct our policy, and also those who have resources. I'll end with a small anecdote. Around this very poor community in rural Appalachia, not on the dilapidated roads, but on brand new roads, is a community of retirement homes. People with incredible financial resources and also skills. Nurses can advocate in these type of communities and build the bridges we need in order to help children of poverty.
Great. Good job. Thank you. I want to start with just a couple statistics. According to most recent census data, about 21% of children under the age of 18 are poor. To put it in perspective, 100% of the federal poverty level, which is how you define whether a family is poor or not, is only, for a family of four, about $24,000. About 37% of all children have lived in poverty at some point during their life. 37%. That is a staggering number. So what happens when the children grow up? Is there a relationship between early childhood poverty, environmental stressors, and adult health status? And I wonder if we can turn to Sylvia. Would you like to tackle that first?
Absolutely. We know that the data shows that children who grow up in poverty, remain in poverty, are more likely to have a number of issues over the course of their lives. They're more likely to have a chronic disease, that they're more likely not to have access to health care, and that they are more likely to have chronic conditions that are unmanaged, leading to more missed days from school and also hospitalizations that were preventable. From a health status standpoint, I think that children who live in poverty, from my experience at a number of the programs that I've worked in, they experience episodic care. They very rarely have any continuity in provider, and they lack the support services that are required for them to be able to remain in care. And I'm speaking primarily in support services, child care, transportation, as was referred to earlier, but having that healthcare system that provides the wraparound services that are critical for children who live in poverty to remain in care. Over the span of one's life, those conditions that are experienced early in one's childhood tend to exacerbate into severe chronic diseases, such as uncontrollable asthma, chronic heart disease. Children who live in poverty are also more likely to be obese and have very few options for fresh foods. We know that food deserts exist in poor communities. Individuals, especially children who live in poor communities, do not have access to fresh fruits and vegetables, and they have less options for nutritious snacks within the schools and in their homes.
Thanks. Charlie, what are you finding with these children who become adults? What's the impact on our adult population if we start with 37% of children who may have lived in poverty at some point during their life.
Thank you. Let me make a few points. One is people who are listening carefully are probably hearing some slightly different percentages from what I said and you said. I mean, the overarching point, I heartily agree, far too many children experiencing poverty. The difference for those of you who care about it really does have to do with how income transfers are handled. So the higher figure, which is from the federal official poverty level, doesn't include some of the transfers such as the earned income tax credit, and the supplemental poverty measure does. There are other differences as well, but it's challenging. As a child advocate, I always want the figure to be high because I want to convey the importance of it. But as somebody who is trying to build faith in the importance of what government services are doing and have the potential to do, I like using this other measure. So simply as a small point to mention. There have been some very wonderfully detailed studies, particularly by somebody named Raj Chetty, who was an investigator at Stanford, published something in the Journal of the American Medical Association just a few months ago, which looked at a county level across the entire United States to look at the impact of poverty and the impact of living in the lowest quintile of the poverty distribution on life expectancy, and found just what you would expect, that there are just enormous disparities, 15-year disparities in life expectancy across the country, depending on from the lowest to the highest quintile. There was variation. So if you're poor, there are places that are better to live. New York City, for example, is a better place to live than some others, presumably because of the social interactions that you have, presumably because of some of the other community services that you might have access to. Using some similar data, some other colleagues of mine have also looked at the issue of intergenerational poverty. If you are in a family that's poor and less likely to move to a higher income over time, you too have a much lower life expectancy. So there's something about the concept of hope, concept of, again, what you were describing in Appalachia. If you don't have hope, that's going to have a profound impact on your health and well-being. Now, we do know a fair amount about the mechanisms of this. I mean, the mechanisms of this, again, I think the neuroscientists and the endocrinologists really now begin to understand how this affects the hypothalamic pituitary axis, our sort of chronic excitable state, the impact on our immune system. In fact, it causes some level of immune compromise, promotes the autoimmune inflammatory response, which relates to cardiovascular disease, relates to the onset of diabetes, in addition to the environmental issues which we've also discussed. So there are many pathways from poverty to poor health, and they're all bad.
The Robert Wood Johnson Foundation has launched the framework around the culture of health, and one of the action areas is creating healthier, more equitable communities focused on drivers of social and economic environments. And I wonder, a question to Sandy, is there an example of cross-sector collaboration that you found that you can identify that is really bringing some of the unlikely partners perhaps to the table to address childhood poverty, some partners that we may not have thought about before?
Well, I think when we're really thinking about children's health, we have to think beyond the type of care that is done in medical centers or in health clinics, and certainly the movement into the schools. We know that children of poverty are disproportionately having learning problems, developmental disabilities, all kinds of problems that affect their ability to learn, and then therefore their ability to be able to move up educationally and out of poverty. So I think there are movements, school-based clinics, which attempt to do a lot more than just take care of children's health, but to see them within the school context.
What about within the economic environment, economic development? You gave the example of the challenges within your communities. Where are the elected officials in this and the folks who really are trying to plan for economic development at any level?
I'm
you
going
see
to
them
pass this
partnering?
on to my panelist.
Okay,
Can I?
that's fine.
Can I jump
Sure.
So one set of initiatives I just want to mention that the current administration, our administration, is moving forward, goes under the broad name of Community Solutions Programs, but you might know them as the Promise Zones, Promise Neighborhoods, Strong Cities, Strong Communities. And these are efforts actually run out of the White House, with leadership from HUD, Housing Urban Development, and USDA, which really is bringing together multiple, at the federal level, multiple departments, and at the local level, community coalitions. So in the many communities that we're working with around the country, it does bring together the business sector, brings together housing, brings together public safety, brings together education. Health is a part of some of these. One program I might particularly highlight is something called the Rural Impact Program. We're working with 10 communities, rural poverty communities around the country, working on 2 generational interventions where we're both starting with early childhood services, as several of us has mentioned, but also working on economic resources and capabilities, community college opportunities, subsidized jobs, and other mechanisms to help the young adults.
Great.
Those are just some.
Good, thank you. Sylvia, how about for you? What are some of the partners that we may not necessarily be thinking about to help us solve the challenges?
Well, I will say I do think that the challenges that we face are solvable. And I think that having a holistic perspective on the solutions is critical. Looking at the non-traditional health components of the community, such as looking at the employment industries, looking at the educational system, having school-based clinics, yes, but also engaging with the criminal justice system, looking at the foster care systems, because that's where a lot of our children engage into when they're in poverty. You see a lot of that interface. But also looking at partnerships within the private sector, because there are many of our private sector partners who want to work with the community, but haven't figured out how to engage. And I do think that nurses are a key component of being able to figure out how to navigate that space. If we were to have that holistic approach where we're looking at the public health from a perspective that includes transportation, employment, also health, I think that there are many, many areas where we could galvanize some level of support and make significant contributions to improving childhood poverty. But it has to be based off of that specific community's need. And I think that the Promise Zones recognizes the importance of community engagement, and I cannot advocate more for community engagement as a part of looking at health, not just for children, but also for the entire intergenerational aspects of what we see in childhood poverty.
You mentioned, Sylvia, the criminal justice system, and I'm familiar with a report that just came out from the Annie Casey Foundation just in April of this year that was titled Shared Sentence. And it talked about the devastating toll of parental incarceration on kids and families and also on communities. Again, a statistic of about 5 million children have had a parent, one or both, incarcerated during their childhood. And so we know there's greater risk of poverty. We know that there's greater risk of instability, whether that's with housing or changing schools multiple times. And I wonder, Charlie, if you could speak to this in some of your work about the link between childhood poverty and criminal justice systems and sentencing.
Sure. Sure, I'm glad you raised that. So it's not only very common, but as Sylvia mentioned, for some other issues, there's a strong racial component here. So I believe the figure is approximately 1 in 10 African-American children in a classroom is likely to have a parent at some point who was incarcerated. It's approximately 1 in 30 overall. So it's a huge burden. We actually there are a fair number of resources that we've assembled that's available through the youth.gov website on children of incarcerated parents. We conducted a listening session with many youth, older youth who'd experienced this. As a healthcare provider, it was actually a bit of a painful session because I asked the youth, I said, so did you raise this with your clinician when you went in? And the universal response was actually striking. They said, no, they're mandated reporters. And so we're afraid that if we raise any of our concerns to them of the problems we'll have, that will be reported to the child welfare system, and that's the last thing that we wanted. So it was an extraordinarily painful area. I would point out, again, the president, as I think you know, this is an area of major commitment of his, is to address the issues of mass incarceration. They have created something called the Federal Interagency Reentry Council. It's done an extensive amount of work. Our office has been very involved, for example, in making sure that Medicaid is available to individuals, both men and women, on their way out from prison. If they're in halfway houses, for example, we've clarified that Medicaid is available, and we've facilitated access to, for example, substance use treatment with all because again, the risk of dying from substance use from an opiate overdose is approximately 15 to 30 times for a re-entering individual within the first month of discharge. So there are a whole number of things that need to be done. I've rambled on a bit. Sylvia, I don't know if you want to add on.
And I do want to add one issue here. You know, we see, I would say, an over-incarceration of minority children. And we need to face that as a fact. We also need to recognize that in poor communities, there is an undersupply of mental health, behavioral health in general, and social support services to support these families. Our children are more likely to end up incarcerated in a lot of cases when they are dually diagnosed with either a substance use condition and behavioral health condition. That situation has exacerbated when they are incarcerated because they're not able to get the support and the services that they need, and they are surrounded by typically adult criminals who then influence their behavior, and it becomes even more exacerbated in a more violent manner when they are released. I think that for the incarcerated population, we recognize that there are huge disparities in access to care at the city, county, and federal level, and where the Federal Bureau of Prison has resources to provide a level of care. Not all cities and counties have the same capacity to do that. When our children are incarcerated, they lack the capacity to be able to access those services at the same level as other individuals in the community. I think we need to take stock in the fact that our schools do need a lot of support for teachers who are addressing behavioral health issues with children who have pre-existing conditions, such as ADHD, and they're not being medicated and not being treated. Those conditions are often categorized as being not only behavioral issues, but violent issues. And they are often put into the juvenile justice system to be addressed, and then it continues on that criminal justice cycle.
Sandy, do you want to speak a little bit to this too, and give us some more details about some of your work at the community level too?
Well, I think, let me go to Jamaica, where I spent a year as a Fulbright scholar. And one of the things that was so striking to me is the lack of jobs on the island. And so you have young men with no possibilities of finding jobs, and then we wonder why there is more violence. And we have mothers who want and have to find ways to feed their children, and the normal resources that we would have are unavailable. And so their behavior might seem not satisfactory to us in what they are doing to get food for their children, but there is no other alternative. And I think also in rural Appalachia, without jobs, without men and women being able to support their children, we point them in deviant ways, and we also point them to substance uses in order to alleviate some of their pain.
Thank you. It's been mentioned a couple programs at the federal level that can assist, that seem to assist low-income families. The Earned Income Tax Credit was mentioned, the Child Tax Credit was mentioned. And I wonder if there are models that the panelists could cite at the state level that seem to be working really well. Or not.
Well, I think most of the programs that we're describing are in fact federal-state partnerships. So, you know, as everyone knows, Medicaid is certainly a federal-state partnership. The Transitional Assistance for Needy Families, which was
Right.
the program that replaced welfare as we know it, is in fact a block grant to states. And so states actually have the flexibility to use their funds creatively to create employment opportunities. I would say many of us are disappointed with how states have used those funds. I think the public would be surprised if they were aware that in fact less than a quarter of TANF funds actually go to provide cash assistance to poor women. The public would probably also be surprised to know that the total dollars for TANF was established in 1996 and has not changed. That is the actual dollars as opposed to inflation. But having said that, and perhaps some veiled criticism there, I do think it's fair to say that there are some states that are doing some innovative programs. I've seen some exciting work from Utah, for example, where they're working on programs on intergenerational poverty and how to rearrange that efforts. I've seen some programs in Connecticut, for example, where they're expanding a very interesting, very important program that's using a group approach to identify low-income women who have a high frequency of maternal depression and providing group treatments for that. It started in New Haven. The state is expanding that to a number of other communities. So there are a number of these kind of efforts around the country. The Buckeye State, Ohio, is also launching a number of programs, for example, on infant mortality and the disparities there. So yes, there are, but we're probably more expert on the federal programs.
Did you want to?
If you notice, every time you ask these questions about all these programs, the three of us look at each other to see who's going to first answer it. And it's not that we don't have programs, and there's not that we don't know these programs work, as Sylvia said earlier. It's just that they are not funded at the level that they can really do the help in a sustained sort of way, not as a demonstration project, but then where do you go afterwards?
And I'd like to make one comment that there are models that have been very successful, and I know that in different spots of the country, specifically, I speak to California. California's program for runaway youth specifically targeted children who were at risk for HIV infected, and provided them with a safe haven. We know that in Massachusetts, with their Medicaid expansion, they focus heavily on linking children with community health centers with a family-centered model to provide them with the wraparound support services that they needed, not only to provide them with the health care they needed, but to maintain their attendance to school and maintain their ability to engage in activities that were appropriate for their height and weight and to maintain that high level of activity. And then also looking at the specific programs in HUD, Housing and Urban Development, that have been, they're often referred to as the boutique programs, but these programs have been demonstrated to work. There are a number of them across the country that focus on homeless children and providing transitional housing where there are gaps in housing or sustainable or ongoing and sustainable housing for individuals living in rural areas as well.
If we look at the federal budget, the share of spending for children remains at about a flat, about 8% of total government spending. One of the organizations that's called First Focus actually puts together a children's budget book. And the most recent one, 2015, and as you can see, I mean, there are many, 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 many programs for children, many that operate in isolation. Of which they're not threaded together. About 3/4 of the budget for children's services is mandatory, which leaves about 1/4 discretionary funding. And I wonder if I could ask each of our panelists, if you were in charge of that bucket of discretionary funding that right now is about 1/4 of all the budgets, that go towards children's services, what would you put that money on? What would be your number one key to turn this around? Sylvia's ready to go. She's been thinking about this for a long time.
Without a shadow of a doubt, community-based, comprehensive, family-centered care, because it has been demonstrated to be a successful model. And I think we have had demonstration project after demonstration project that have shown success. But again, the funding level is not there to build sustainable models across the country. So I do think that having a coordinated planned intervention that can be evaluated and tested in a way that produces true results for the community, based on community need. Those would be successful models, and I put my money there.
There you go. Sandy, you just got a big bucket of money there for discretionary funding. What would you,
Well, being
I bet you've been thinking
completely
about this for a while.
objective, I would support insights into children's temperament and expand it across the country. But that's just my objective opinion.
I think I might vote, I mean, there are a lot of wonderful options, but I think I might vote for universal childcare. Because that has, you know, it's got a double effect. If it's a high-quality child program, it provides the early childhood stimulation and support that we need. And we also have very clear data that says when you provide childcare, women are more likely to work and be successful in their work, which would promote self-sufficiency and a more virtuous cycle of moving up the economic ladder. So I think that would probably be my preference.
And more money in one program rather than the multiple programs?
Oh, I thought you asked us only to do one.
Well, I think you have to go with what the community wants and partner with them. You can't dictate it and impose it.
Sure. Good answer, great answer. A question from the audience. For most broad societal change, there's a tipping point. How will we know when we're nearing the tipping point where childhood poverty influences our economy enough to lend to regulatory action or other action? When is enough for the general public to rise up and support universal child care, support community health? What's it going to take?
One thing is we have to realize that these children who are now children of poverty, they're not long afterwards become our caretakers. And that may push us into thinking that we've got to support them for all of our society's benefits.
So probably not speaking as a member of the administration, but as an individual. I mean, when you look at how we treat the poor and our programs for the poor and compare those to most of our other comparison nations, the European nations, we obviously do far worse. And there clearly is, well, in my view, there is likely a component of racism that's connected to this, or at least a belief that the poor are the other. So, because I don't think, how much more prevalent could the poor become for it to be a major issue? So I think it's really more a question of leadership and a question of the population identifying that this is their children and not somebody else's.
Who's leaders? Which leaders?
I think there's leadership at all levels. Certainly the president would be a critical leader in this, but I think there's leadership at every level, from the community to the state to the federal government.
From a policy standpoint, can you recommend some actions that the Academy should focus? How can fellows make an impact in reducing barriers for families and communities and states to be successful in reducing childhood poverty?
Well, I think nursing has always been concerned about children of poverty. This is nothing new for us, but perhaps we can do a much better job of working together across various expertise so that there is continuity of care and so that we reach out more into the community and to other environments where children are.
Sylvia?
I would say that we could leverage our relationships a lot better and use our influence to create opportunities for change. For nursing to be the largest licensed healthcare profession in the world, I don't think we use our influence as well as we could. And I think together, collectively, we all have to get to the point that we are willing to lock arms and take up the issues of health. And I don't mean sick care, I mean health, and approach it in a way that will allow us to consider the needs of the community, the needs of our profession, and to have our voice heard at all levels, whether it be at the local, state, and federal levels, I think that would get us a long way. For so long, I think our profession has been silent on the contributions that we make to society. And we are the unsung heroes. And I think over time, we have began to understand how powerful our voice can be when it's heard. We just need to figure out how best to be heard and to say things in a way that it can be heard, utilized, and create that opportunity for us to then be at the table and make those decisions along with our colleagues. In the policy realm, I think nurses have often shied away from the dynamics of making tough decisions. But we have to take that on as our new mantra, that we're willing to make the hard decisions, make the sacrifices, and be a part of not only the policy discussions, but be a part of the solution once the policy decisions are made. I think that's where we can make a huge impact.
Excellent, excellent. As a bit of a commercial, we've just come back from the leadership workshop, very dynamic discussion this morning. And one of the priorities, of course, for the Academy is to place more nurses on boards, commissions, and councils, because we know that it is so much more fruitful for us to be at the table and making policy rather than trying to turn policy around after some bad decisions may be made. And one of the things we're doing at the Academy, of course, is trying to link all of our fellows with all 50 governors' offices to let our fellows know where the openings are. We have excellent working relationships with most of the governors' offices. And I would just add to what Sylvia just said about leadership, is that when we do reach out to the fellows and give you the one contact name of each governor's office and their website for the array of boards, commissions, and councils, most governors are filling, 1,000, 1,500, 2,000 slots for voluntary positions, to please read through all of those, because many of the issues that we've talked about are well, outside some of the traditional healthcare boards, commissions, and councils, and we really indeed need nurses at all levels. I would like to thank our panelists for being with us today to raise a number of issues. Thank you so much.
Thank you so much. And I just wanted to mention that the Academy also has not a new initiative, but one that we're focusing in on childhood poverty, to Sylvia's point, and the stress and toxicity of that relationship. So I think the Academy is well positioned to take this on. So thanks again to our panelists. All right, so thank you all for making this first day fascinating, challenging, productive, but it's not quite over yet. So first, we'd love you to stop by the e-poster sessions. They're open now in the marquee, which is just right next door to this ballroom. So also, there's the Fellow Selection Committee that's hosting a dialogue about, for those of you that are really interested in nominating new fellows but want a little more information on the process for that and how to do that. That's going on in also the Marquee Ballroom, 12 through 13. Tomorrow promises to me a very informative and full day, so despite the fact that we're partying late, get a good night's sleep. Because there's an Edge Runner breakfast first thing in the morning, then there's 2 plenary sessions beginning here at 8:35. And then we're going to move into an afternoon of the policy dialogue sessions, each one 3 concurrent policy dialogues to choose from. So lots of stuff to do. But tonight, we're hosting our Living Legends celebration with a special ceremony and a dinner. So we would love to see you back here by 6:30. So take a careful look at that very complicated and very long schedule. The ballroom doors will open here tonight at 6:15. We'll see you then. Thank you.